right, if y'all don't know me, my name is Lucas. I know Amy said that I'm a supervisor, but I'm not really a supervisor. I'm a backup supervisor to our
I have to say that.
our normal supervisor is Joanne. I do have PEDS experience coming from UMC. I worked in their PI for 4 years, so that's where all my PEDS experience comes from. What questions do y'all have for me so that I can make y'all comfortable with this?
Can you do it instead of Christy?
Do what?
Just be our RTL full time, please.
Well, I'm not here every day of the week, so that's hard.
Just kind of go over the system and what the purpose is. And
I know nothing about HighFlow. I'll just be honest. I'm just saying. Yeah.
So the mode in which we're going to focus heavily on work of breathing, like when you see retractions, tachypnea, stuff like that, is HighFlow. So, like our little guy down there in 51, he was retracting and breathing really fast on a good bit of HighFlow. So they called him, wanted to get an ABG, and then we started continuous on him. So this is missing the heaters, of course, but you would have a heater plate down here. That's what you would have to hook the rest of the HighFlow parts up with. But just for grins, kicks, and giggles, this is the nuts and bolts of it. So one side is, it has two, but one side, if you had to give like a treatment or something, it just gives you an extra place where you can deliver an oxygenated breathing treatment or something too. And one side is going to be hooked up to your heater plate that's going to deliver your flow and oxygen to the patient. However many liters that may be, I'm sure they're going to at least start him out on 4. He's on 11 liters, so anywhere from that
Holy
range.
shit. My bad, sorry.
it's been a day.
And this center part is the blender. Y'all know what a blender is. It just allows for the 100% oxygen that is being delivered in here to not be 100%. So it allows for lesser oxygen.
So whenever you say that he's on 11 liters,
Correct.
how much oxygen is he on? Because that was one of the things that initially I used to get confused at.
So,
You know what I'm saying? And then it's like, no, this is just a flow, but the oxygen is actually different, correct?
Correct. So when they're on HighFlow, this controls how much oxygen the patient is getting, whether it be 35%, 45%, 40%, 50%, 100%. This controls that.
Okay.
The flow is what is going to alleviate the work of breathing given to the patient. So,
And that's going to be the green.
correct.
Okay.
This is going to control this flow.
Okay.
The flow is essentially your pressure.
Okay.
Correct. It's 11 liters is going to give off a certain amount of CPAP because they're not really going to be able to deplete all that 11 liters quickly because it's being delivered right in their nose and it's kind of, they're breathing through that 11 liters that we're giving them. So it's going to give them a little back pressure to kind of help them keep their lungs expanded, keep them clean and open for us.
I have a question.
Sure.
So soon after report, Dr. Myers said we can increase the flow. So I put it to 11, but then kept the same FiO2. He was having coughing spells, and the respiratory therapist was like, let's adjust the FiO2 and turn it down because maybe that was like not like coughing and getting him choked up. So is there too much liters like that can get him coughed up like that?
I think at first he hadn't been used to it, right? He wasn't used to the 11 liters that you're delivering to the patient. They're not normally seeing that. So the coughing spell is a normal reaction is what I'm trying to say.
Okay.
There's not really too much or too little that you can deliver to your
Liter
patient.
of flow. Okay.
Correct.
So it's not
So
based on weight of the baby. Okay, I don't know what Dr. Myers was talking about then.
You always are going to
Yeah.
deliver what you need to
Misunderstood. Okay.
alleviate your work of breathing. So if your work
Okay.
of breathing looks bad, go up.
Okay.
And the best thing that y'all can do is communicate with us.
Okay. So, work of breathing, adjust that one. Oxygen saturation
This keeps
is
your
the FiO2.
This keeps your SAT good. This keeps you
Yeah.
at 100% or whatever you want to keep the baby at. 90s to 100, whatever you need.
Okay.
This one.
That being said, like if you go up like a liter, because like your kid's been fussy or whatever, and you're alleviating, you just want to give them a little pressure to help them get over that hump.
When he goes
If
back to
you can't
sleep.
get them back down,
Okay.
and you're having to go up again, like that's where you get into the territory of talking to your physician or talking to your respiratory, because you don't want to just keep on bumping for 4 or 5 hours.
Right.
Yeah.
You know,
And not
nobody
have
knows.
somebody know what's going on.
Yeah.
Because I mean, we're going to be coming by to check these nowhere near as much as y'all are, because we're all over the place and y'all are in and out of the rooms a lot. So we rely on y'all a lot to communicate with us, tell us what's going on outside of the assessments that we do.
So how much freedom, because how much freedom do we have on like she was saying, like if he's really fussy? I mean, is that okay? Is that sort of kind of what is expected of us? Are we thinking, okay, he's just fussy, let's bump him up, and then whenever he calms down, turn it back down? Is that
That's what you need to happen.
so? I just don't know.
That's just with your comfort level. Like some of us are going to be different, because I mean, like me and Reggie, we're used to HighFlow all
Right.
the NICU, so we may not necessarily call just because we go up a liter or two, or just so we bump the oxygen up a little bit.
So am I calling Dr. Myers or Dr. Quigley, or am I calling
I
you?
would call him.
Okay.
Yeah, call them first. And see what they think, and they can assess your patient. And then that way you got two
Yeah.
people, like this is what I see versus this is what you see or whatever. And that gives you a little more information to give
Two
the
brains is
physician
always
when
better
you
than one.
actually
Right.
call the doctor. So
Okay.
there is, and that's something that'll increase with your comfort level as you have more kids that are on it. You get used to it.
Okay. I it's just something I haven't dealt with a whole lot, and I'm starting to get a lot more comfortable. Like when we had that kid that went really bad, I was glad Teresa was here, but I think, okay, I would have handled that sort of kind of the same way that we did. And so I felt better about it, because I was like, oh God, if it would have happened the day before, it was me and you, me and Tiffany. I'm like, okay, would have I been as calm and know exactly what to do like Teresa did? And I did, except that's why I was telling her we've got the paperwork with all of the numbers, and I'm going to be working on making a cleaner copy of that, so all of that information is just at your fingertips. You don't have to hunt for it.
So this is just what we're going to be starting with doing until everyone is comfortable, competent with this. Anything above and beyond this would be kind of spur of the moment, need basis. We have the capability to do more, just depends on what happens.
I have a question. We had a kid that was on HighFlow, and we were told to increase the flow, which we did. But the respiratory therapist told us that not to do it because we could blow their lungs.
HighFlow is not going to cause barotrauma.
No,
That's what they told, and that's why I was asking you. I mean,
HighFlow will not cause barotrauma.
okay.
Now, when it comes down time for weaning patients on HighFlow, be aggressive.
Right.
Mhm.
And I would start with your FiO2 first.
Okay.
And get it down as little as you can get it. I would say if you can get it to 30%, that's a good judgment that they may not need all the flow anymore. And if they're tolerating it well. Now if you're having to like put it down and then go back up and back down, kind of seesawing thing, they may not be ready yet.
You don't have to chase them.
How much do you typically, like on our other, we do like half liters. How how much is an appropriate amount, like if you are trying to wean the FiO2?
I go down by 5 personally, 5 to 10.
Like 5% on the oxygen and then a
Yeah.
liter usually on the flow.
Okay.
And there, that goes, and I think that's probably been our biggest hindrance on people learning and getting comfortable is, it's just kind of a culture thing where.
Know this, your patient will tell you whether or not they're not tolerating it, and you can always go up.
Okay.
So there is no right or wrong answer. You can go down by 10, you can go down by 5, you can go down by 15, however much you want and feel comfortable doing. Your patient will tell you yes or no. And then you just fix the problem.
The main thing is just don't make an adjustment and walk off. Like I usually will stand there like 5 minutes or so.
You always want to lay eyes and keep eyes on your patient when you to make sure they're
Especially when you're weaning, like you really want to, you don't want to wean too fast either. You don't want to bump them down 5 to 10 or 15% on their FiO2 and then go in there 30 minutes. You know what I'm saying? You want to give them some time to adjust because when you start weaning the FiO2, they've got to adjust to that decrease in oxygen.
Right.
So you've got to give them time.
Oxygen is a drug. Just plain and simple. Oxygen is a drug, and surplus given to somebody, they have to get used to not having that surplus. So that's it. Now, continuous. What makes y'all uncomfortable about continuous?
All right, are we talking about like continuous nebs, or are we talking, because the HighFlow is continuous,
This is
right?
separate from that. The
Okay,
The
all right, so
heart
we're,
rate, I mean,
all right,
you
we're going
get
something
higher
totally
and
different
higher
now.
and higher
Okay.
and higher, you know. I mean, you need to be over 200 at times, I'm thinking.
That is going to happen with albuterol. It is a side effect of albuterol. Tremors, hyper,
Not sleeping.
fast heart rate is a side effect of
At what point do we need to be concerned that?
when
I
it
mean-
gets up and stays up. At that point, contact us, doctor. We may have to like just pause for a little while and let it kind of deplete out of their system a little while and start back.
and I am so sorry because I'm going to have you to go down into elementary mode here. Just simply because I don't know, and I'm thinking, okay, if I don't know, somebody else might not know, and I'm not bashful, I'll ask the questions. What drug is it? I mean, is it always albuterol that we use with continuous, or what?
Not always.
Okay, so tell me sort of kind of,
So we can use albuterol, we can use Zopanex. The only problem with using Zopanex is that we are only able to do 25 milligrams an hour with Zopanex, which is probably going to be a little bit too much for our patient size population. So the targeted med dosages are going to start at 5 and go to 15 for albuterol.
okay,
And there's a formula that we use to tell us how much albuterol we're going to put out to how much saline we're going to add to it to deliver. The syringes last about 3 hours.
and y'all handle that. Y'all change all of that kind of stuff. We don't really do anything with
Set
the
it up,
continuous.
Get it started, scan the med, and all of that. The only thing we would need you to do is notify it when it alarms that it needs to be refilled.
So, because I've never taken care of a kid on continuous. So, is there going to be something going from
Yeah, the syringe,
there
the syringe
to like that other side on the
syringe sits in here and it has like IV line that
right?
fits into the neb cup.
Okay, so if they're not necessarily on HighFlow, if they're on continuous, or is it always?
So there's another way we can deliver continuous, and it's going to be hard for patients to wear a mask all the time delivering a continuous through it, especially for a little one. You know, they don't like stuff on their face to begin with.
So typically,
this
it's going to be a
is-
nasal cannula.
Yeah, this is
It's
going to be
easier
our
to do
go-to.
it through HighFlow than a mask because the mask irritates kids more than the HighFlow.
Right.
Okay,
Because the continuous is going through the nasal cannula.
Okay, so the high flow is always on a nasal cannula.
Yeah,
Okay.
up their nose.
And kids are often getting nose bruisers as it is. So the high flow, the medicine's going through their nose. It's a win-win.
You still
Okay.
don't want them to eat or drink while they're on high flow or continuous, correct?
Right, because all this medicine, you might upset their stomach. You know, it might puke at you, so be careful.
So no eating NPO.
I'd be careful.
On just continuous. High flow, they can still.
Depending on
I'd
how
be careful
much,
on high
because
flow.
it might affect their swallow, because remember, it's giving them some back pressure.
Yeah.
They
So
may aspirate
I
easier.
would just refer to Dr. Myers or quickly on what's her
Okay, so this is how
threshold
I
for.
explained to parents about me and Dee when we were in Nikki explained like really when you're doing a lot of pressure with high flow CPAP and all. So it's difficult for them to eat. Just like, so imagine if you and I were going down the road at 60, 70 miles an hour, sticking our head out the window trying to suck through a straw. It's impossible. It's hard. You can do it. It's hard. That is what they're feeling when they got that much pressure going in, either whether it's high flow CPAP or whatever. So you want to just be careful and like consult with the doctor about what they want to do with that, like Lucas was saying. That's the best analogy I can give you.
Okay. Well, I'm glad you said that. I mean, because that's something else that I'm going to just feel inadequate about teaching the parents because I'm asking you all of these questions.
Yeah, it's just a lot of flow, a lot of pressure, and it's hard to swallow when all that's happening.
Yeah.
And really, if they feel bad enough that they're on all that,
Yeah,
they
they
probably
don't.
won't want to eat anyway.
They're not going to want to.
They're not going to. It's not like they're going to
reserve up. They're going to use their reserve to breathe, maintain, and they're not going to want to eat. If you're in respiratory distress, you're not going to want to eat or drink anything because you're using that reserve up. Because that reserve, you're using all that energy and reserve up to breathe and get those respirations down versus wanting to eat and all that stuff. Does that make sense?
Yeah. And then my other
And
question,
they usually have IV, so when they're getting their nutrients, they're not getting dehydrated.
right?
So like I would rather them, I always tell parents, I don't care about them not eating or drinking anything. They got an IV, they're hydrated. I'm more concerned about the respiratory thing. I could care less if they eat or drink anything.
Right.
As long as they're wet and diapers good and the IV rate is adequate and it's in your eyes, nose are equaling up from your rate and your output, I could care less if they eat or drink.
So then what signs are we going to see when things are deteriorating worse that we need to be more concerned about or, you know?
Like, should we keep a mask and bag with the high flow? If they have high flow, they probably have the chance to, like, deteriorate.
I mean, there's always a chance, yeah.
Okay. So
You always need a bag and mask and suction.
I would
at the
always
bedside,
have bag
any
mask, suction, and stuff
respiratory
at the bedside.
period.
Okay, so we need to have bag mask and suction at the bedside.
Central has, well, there's some on the, one on the code card, but Central has some.
Okay, because I hate to pull that one.
You have to,
Yeah, I mean, like
Yeah.
you.
No, but I meant for
you
just to
know,
have.
code card, like, I mean, I guess it's me and Dee's ICU brain, like, we're always called, like, you need your
For
bag,
safety.
mask, suction at the bedside at all times.
Yeah.
Whether any respiratory kids, because they can go down real quick when they go down.
That's on that list that she kind of referred to put a section in the room.
Yeah.
We'll try to, tomorrow, we'll try to get some extra bag and mask from Central.
Maybe if we can get like a bag, would this be acceptable? I mean, can we like get a bag and mask and put like on every one of our high flows?
Yeah, 'cause
You know
that's
what
a-
I'm
that's
saying?
an extra, so-
Because that's going to be that's going to be when we're going to need it. But you're going to want that in the treatment room. Yeah, but for
That's what
tonight.
we set this up in here when we were cleaning, just so you have equipment, just in case. Well, not this, but like we put the bag and mask and
Yeah, we have the
suction. And
suction
Amy
stuff.
said that they're gonna order some more like suction.
The little
pods,
white
just
holders.
get more- Yeah, order some more of those so that we have one in every room, cause now we only have a couple. So, there'll be one in every room already set up, all you'll have to do is stick your canister in it, so you have it on.
There'll be signs too, like you'll be able to tell it's not working. Your retractions are not going to.
Right, that little girl.
And like when we started at her on the high flow, she actually got worse, but it was because of what she had going on.
We were just trying to stabilize her with the best efforts that we had.
Intubating.
That's all we could do.
Don't want no
That's
more
all
of
they
those.
would let us do, but it like that.
Gotcha. I know.
Because we were our hands were tied once the ER got involved.
Yeah.
What other questions do y'all have?
One of the things that was mentioned the other day was like whenever the doctor had put in an order to change the frequency of a treatment, it was going from every 3 hours to every 4 hours. And she put the order in like at 8:30. So normally this kid would have been getting a treatment at 9, but she was just going to extend it another hour. So she wanted the kid to have a treatment at 10, you know. And whenever we contacted the therapist, then we were told that no, that y'all do treatments at 8, 12, and 4. And we're like, well, this is a different situation.
So you can give a treatment an hour early or up to that, and within the hour that it needs to be given. I don't know who, why, what, when on that, but if Q3s are going to throw your timing off
Horribly.
anyways, just because it's a weird schedule.
Right.
So once you're going from Q3 to Q4, they're going to be off. It's just,
It would've been 6 hours.
it,
So how do we handle that without making people
so
mad?
just say the
That's what
doctor
ordered.
has
That's what it
ordered
is.
this patient to get a treatment here. They need a breathing treatment in.
And then we call you if it doesn't happen. I mean, we just
Yeah.
need to know how to handle it.
Because I mean,
Well, he can't answer like for every
Oh, I know.
situation because how he practices versus how they all practice versus how you or I are,
Right.
everybody's a little different. So
And I get that. And I get there's only one of y'all covering a bunch of patients. I do understand that, but it was just sort of kind of like it was pardon?
Kim, let me interject here. Lucas, I just think that was a particular situation because the kid was going home,
okay.
so they wanted to watch him for a certain time.
Okay.
So would you suggest if a doctor is wanting a kid to be able to get 2 treatments before they're going home at 2 o'clock,
Yes.
then they just need to write an order for a one-time dose at 10 and then, in a one-time dose at 2, and that alleviates it instead of writing the order for every 4 hours.
I would agree with that, so that it doesn't make it look like
like
they're
it's gonna be something.
going to be
Right.
keeping.
The schedule.
Okay.
That
So
crazy
that's what y'all need
schedule.
to think about in those particular situations, because normally if they're just gonna be in the hospital, waiting
Right.
that 6 hours may not be a big deal. That was just a particular thing with that kid and them trying to get him discharged. Okay, I'm done.
What else do y'all have?
Mine is probably like NT suctioning. I'm not the most comfortable doing that, and I don't know if it's like if it will make more things worse with creating more secretions, or how often, when is it necessary, because I'll ask respiratory because I'm not like I was like, do you think that's required? Like, I think they sound really croupy, and they're like, it's mainly upper, so it's not gonna affect anything or help. So I just didn't know on what I should do in this.
Suction.
Go.
Just go for it.
Okay.
You don't have to go real deep too. You're just trying to stimulate a cough.
Okay, so if he has a good cough, but he's swallowing it every time,
I mean,
just
that's
'Cause he already
byproduct of
has all-
suctioning. They're going to swallow.
okay.
So it is what it is.
There
There.
in his stomach than his lungs.
Yeah. Now there is a line where it could be too frequent. If you're starting to get blood when you suction, you're probably anti-suctioning too much
Okay.
because it's a very vascular area. Kind of frequent anti-suctioning is going to make them raw,
more.
tender, hurt.
Well,
But if they need it, I mean, they got to breathe through their nose somehow. So
And you keep the high flow in
yes,
when you suction.
yes.
Okay.
Oh, good question, because I hadn't thought about
I
that.
didn't know, like, to
I mean,
remove
you're gonna have to
over-
make a little space if it's like occluding a little.
Okay.
You'll have to make a little space so you can fit your catheter down. But it can stay in their nose.
you want them oxygenated like your.
Oh, higher the FiO2?
You can
Increase
pre
that?
oxygenate them. Yep, if you're
Okay.
worried about desaturations and them holding their breath or whatever.
Keep
we-
them upright or
Sure. Upright, because
Laying
well,
down.
I wouldn't say necessarily flat because if they puke or gag,
You don't
then
wanna
have a-
aspirate,
You
okay.
don't want them aspirate. So I would say like on a semi-fowler.
okay.
And just take advantage of your opportunities when your respiratory therapists come up here to do things. Say, hey, let me go in there with you. You know, I'm not comfortable with this. Let me come watch you,
What time
or
do you
will
see
you let
it?
me? Will you let me do it and you watch me? And you know, I think we just kind of need to work on everybody's kind of got their territories that they don't want encroached upon, and we've just kind of got to break that culture so that we're all just trying
This
to
is
do the
about
best thing for the patient, not
Right.
that's my job versus that's your job.
Yeah.
You know, so everybody just kind of needs to
Work together.
move away from the culture of mine versus yours, and everybody, you know, if it's in your scope, there's no reason that a respiratory therapist can't teach you how to do it. And I mean, really, that's kind of to their benefit, because when you get to the point that you're more comfortable with assessment and things like that, that's you not having to call them from being busy just because you need your kids suction real quick.
Yeah.
Now, if you suction and
Listen.
you're not getting any kind of result, you know, you're still worried, then you can call your respiratory therapist to come and see what they think, you know, and
Let us know too that you suctioned.
Yeah.
It's not going to be a bad thing. It's just
you just don't want them to come in right behind you and do it not knowing you did it.
Yeah, okay.
Exactly.
Cool.
Sorry, took over your meeting.
no, you're good. You're good. This is open. This is question and answer.
Yeah.
I think we're gonna start with this, and it's gonna be, we're gonna get real competent, comfortable with this to the point where the doctors believe us. And then we'll take another step. And we'll probably have another meeting.
We'll see.
Another step. I thought the next step is Batson. Okay.
Not eventually.
Not eventually. So eventually we're going to be having a PI?
I'm sure,
Okay.
because eventually, you never know.
Okay.
I mean, we took on a burn unit apparently and didn't know we were getting that, so I
Still
mean,
got
I'm
the
not
first
gonna ever
aid.
say what they will or
Damn,
won't
that's
do,
hurt.
so, you know,
Yeah,
take
that's
advantage
hurt,
of the opportunities to move slow versus, hey, guess what, guys?
You're
Look what
thrown
we're
in.
doing. So,
Have a
you
good
know,
patient today.
Any other questions, ladies?
I don't-
Feel free if you see me or Christy or whoever you feel competent and wanting to ask questions or talk to, feel
She
free.
did say that you had more peds experienced nurses that y'all were training.
Or RTs.
RTs.
Yes.
I mean,
Yes,
the
so
RTs. What did I say, nurses?
I'm hoping that we can get 8. That would be 2 for days on both tracks, 2 for nights on both tracks, so that we are well versed and well covered. So if one is out, another one can come in.
Cool.
The RT y'all have tonight's really good.
Ben, I love him.
No, not Ben, Rachel.
Oh, yeah, I love her too.
She also will have a unit too. So give her grace.
Oh, definitely. I got her number.
Okay.
Thank you.
Thank you.
Yeah. And we've got the green bag for the treasure chest. There's going to be a green bag in there where all the kids' toys are, that kids can have one anytime you want to give them one. They're just little bitty happies, like you know when you go to the dentist and you just pull something out of the drawer. We've got a treasure chest. The treasure chest isn't here yet, so that's why you got a green bag that's going to be in there for the ones that I don't see. But Dee can show you, Ray Ray.
Well, it's not-
Amy, you need talk time?
The
Yeah,
air
just
on
for
this
a
is
second.
controlled
Okay.
for this.
You got,
Do y'all still need to report and everything?
yeah, you got 8 minutes and 7 seconds before my free meeting ends.
It won't take me but a second, but I'll wait till they get through.
And you're delivering 100% through your bag.
Okay.
Amy's got a quick talk.
Sorry.
No, go ahead.
Hey, no, it's okay. I just wanted, while I had the majority of people in one spot, just to tell y'all at the same time, it's nothing big. It's just something I'm being held accountable for. And so I want to pass it on and just let y'all know. They're coming down really hard on us about bedside shift report right now. And I know we don't want to wake up the parents and stuff like that, you know, early morning. They've been up all night and that kind of stuff. So this is what I'm asking. I think it worked out for me when I was having to do it over at Woman's. On my last round at night, when I knew it was the last time I was going to go into the room, you know, and have to disturb them, I would just mention to them, hey, we're coming back in here at 6:45 to give bedside shift report, but we're gonna, you know, try not to bother you and wake you up if you're finally asleep, unless you want us to. Do you want us to wake you up? You know, that way they know, hey, we're doing it, you know, and they have the choice of, yeah, I want to hear or whatever, and just let them know that. I know we talk mostly at the, you know, table and just talk to each other, but we are supposed to be going in and introducing each other and all that. I'm just getting, they're really holding us accountable. So I just want us to at least tell our patients we're doing it so that they've heard that we do that, if that makes sense. If y'all can help me out with that so I'm not getting in trouble.
Okay.
Thank you,
And we're gonna be
ladies.
getting,
Thanks, Lucas.
Oh, no.
all right.
Okay.
Bye, y'all.
Bye.
Thanks, Lucas.
Thanks, y'all.
All right,
Bye.
thanks.
Talk to y'all later.
Bye.
Bye.